All right, everybody. Welcome back. So we're on to this will be our week 10 lecture, our second week of moving to online. I hope this format is kind of working for you guys for the best part. Hope you guys are adapting as well as you could be. For those of you who are kind of struggling, I haven't heard about anybody struggling so far, and so but at the same time, I'm not going to assume that everybody is doing well. So if you're struggling, if you're having a hard time kind of getting a grasp of some of the content, please, I invite you to make sure that you're engaging in the discussions, um, that we have in the chats during those times that you would normally have lecture. That gives you time to kind of clarify. I make myself very available to you guys. So, anyways, I think what I'm going to do this week again. Last week, people seem to appreciate the fact of having two kind of lecture times, so I'll swing for that again this next coming Tuesday. So next Tuesday, that's going to be the 30th, so March 30th. We'll do lecture at our normal times, so that's the normal time that you guys would have lecture anyways. So I'll be in the chat in the Nurse 149 module at the normal time. So I'll be there at 9 o'clock and I'll be available till about noon or whatnot. It's kind of engaging. I thought you guys were asking a lot of really good questions. You guys brought a lot to the table to discuss as well. So I thought that was pretty cool. And so Tuesday I'll be in here, in the chat from 9 to about noon. And then again, for those of you, like I said, for those of you who have kids or some of you guys who work nights or, whose schedules are kind of off, um, things are a lot different now, so I'd like to try to accommodate you guys as much as I can. So I'll be on again at 8 o'clock as well. And I'll give you guys as much time as I can. So anyways, let's move on. Personality disorders. We've already touched a little bit on this, so I'll try to kind of, on one hand, I try not to repeat myself too much because for some people, I know it kind of drives some people crazy, but at the same time, I kind of feel like when we go over the subjects a couple times, when we not necessarily repeat ourselves, but when we revisit certain issues and certain concepts after you guys have built up more knowledge, once we go back and revisit those, I feel like there's a lot more to come out of it. I feel like you guys can kind of reinforce some of those concepts. So, on one hand, like I said, for me, it's like I really don't want to repeat myself, but at the same time, it's not like we're repeating ourselves. We're kind of reinforcing previous concepts. And the more we hear it and the more we see it and apply these things, especially in the context of other aspects of mental health that we've learned, I feel like it gives you guys a better picture of how to see the bigger picture. So, personality disorders. So, one of the things that I've brought up with you guys before is that overall, the personality disorders, um, they can be difficult. Okay, so we know that with personality disorders, there is a very complex, um, the process for which they develop and the processes and the factors that we take into consideration when we try to identify how these things happen. They're pretty complex. It's genetics, it's environment, it's behaviors, it's learned behaviors, and ultimately they're all very deeply rooted problems or deeply rooted, you know, they're deeply rooted things that build up over a long period of time. So we got these three clusters. Now, back in the day, actually not even back in the day, it really wasn't that long ago, but before we used to kind of identify mental health illnesses according to axes. There was axis 1 and axis 2 and axis 3. We don't do that anymore. So for those of you who are thinking about, the axes, the axis categories of classifying mental health disorders, because I've seen some of those in your presentations, and this isn't kind of the same. So get out of that axis. If you notice, I haven't touched on the axis because those aren't used anymore. So anyways, with personality disorders, there's three clusters. You got that cluster A, cluster B, and cluster C. That cluster A is that those eccentric personality disorders. Those are the ones, for the most part, those are the ones where Patients can kind of be seen as odd or different, very awkward, very, you know, uh, very social isolating. And of course, as the name implies, there's a lot of schizophrenic uh, characteristics in those. Cluster B is those borderline, narcissistic, histrionic, antisocial ones. Those are the challenging ones. Those are the ones that I've touched on a little bit already, that we've talked about a little bit already, and those are the ones where those are challenging. Cluster C, those are the ones too where they can be challenging as well. Just as the cluster Bs can really kind of get under your skin, they can really test your ability for self-assessment. Cluster Cs can really do the same thing. They can really kind of get to you. Um, they really test your limits for professionalism, but kind of on a different level. So again, and as I mentioned already, with these personality disorders, they're pretty tough, not only to treat, they're pretty tough to handle on a professional level. This is where your ability to put up boundaries and to put up limits and to take care of yourself, to carry out those self assessments and to check yourself. That's where this comes into play a lot. So the biggest thing with one of the biggest things that we talk about with these personality disorders is that they have a lot of problems, usually with emotional regulation. They have a lot of problems with forming close relationships, healthy close relationships. They have a problem with intimacy, having healthy levels of intimacy with people, those very close, intimate relationships. But there's also a very strong problem with identity. There's a very strong problem with, their esteem and with their self-value as well. But one of the things that separates these personality disorders from other disorders, and I say this carefully, just as I try to say most things carefully, with some of these personality disorders, such as when we talk about antisocial personality disorder, when we talk about narcissistic personality disorder, there is still a level of accountability with the patients. This isn't like some of these personality disorders. They're not like that manic patient who they have that serious chemical imbalance and they're super manic and they can't control their behaviors. And then they come back down and they're like, oh my gosh, like, I can't believe the choices I made. This is completely embarrassing. This isn't like that. Some of these, there is a level of accountability with these folks. They know what they're doing. They recognize their behaviors. And so, the factors that we have to consider when we start checking our professionalism and how we engage with patients, we have to think about that a little bit differently. So, about 6% of the global population has a personality disorder. So if you kind of think about it, when I'm going to kind of use the supermarket example with this, I'll kind of let's just think about the supermarket, going to the grocery store. If you think about that 6%, if you go to a grocery store, that means between about 3, maybe 4 people on a busy weekend in that supermarket. You go to Walmart or Target or wherever, about 3 or 4 people out of there are going to have some kind of personality disorder. So, it's pretty common if you think about it. 50% of psychiatric patients, that's pretty incredible. That's absolutely incredible. So when we start thinking about that, that kind of brings it home because, how many patients are we going to see that have mental illnesses, regardless of whether you're on the med surg floors, whether you're in the outpatient, nurses health, community health settings, so it's pretty common. With these folks, one of the biggest things, and I've already touched on that a little bit, is that this emotional dysregulation, that inability, gosh, I can't even keep those lines straight to save my life. That ability to regulate their emotions in a healthy way, and to regulate their emotions as far as reacting to things, in accordance with how society would view them as normal. There is obviously an imbalance there. The risk factors for this, where does it come from? Strong genetic factors with some of these. Not only regarding the development of the disorder itself, but also determining what kind of traits are inherited. So when people have certain personality disorders, they don't inherit all of the traits of those disorders. Just because somebody is schizotypal or somebody is borderline or somebody's narcissistic doesn't mean that they will absolutely carry all of the traits of those disorders. So if you take somebody who's narcissistic, right? Maybe they don't have that aggressive, maybe you have somebody who doesn't have that those aggressive characteristics of narcissistic personality. And that may be because there's the family history of narcissism. They're not typically aggressive, you know. And on the other side of the flip coin, let's say you have somebody with that, like the borderline uh, personality disorders, a strong genetic component with that one. Maybe there's not a strong history of, maybe there's a strong family history of borderline disorder, and there's also a strong family history of those anxious symptoms that come out of that. And so, I don't know, hopefully that makes sense, but there's traits for the disorders, and those traits are really what follow genetic lines pretty strong. So, and of course, there's a neurological component, right? There's usually always some kind of neurobiological component as to why or the things that cause these issues, right? And so hormones, obviously, that regulate temperament and emotional control. We're going to see how some of the corticosteroids or the CRH, the corticotropin releasing hormone, has a big impact on some of these as well. So there's a couple explanations as to where this comes out of and some of the comorbidities associated with it. Freud has, I'm not going to go too much into Freud. Basically, he has this idea that personality comes out of childhood experiences, and that use of our defensive mechanisms as children. So as children, if we use repression a lot, if we're repressing things, if we're using suppression a lot, so suppression as in we're not processing our emotions, we're suppressing them down and we're keeping them bottled up. Regression, that childlike behavior in which we kind of go back into previous years or previous maturity levels of reacting to things. But our use of those determines whether or not we get these, and determines the expression of personality disorders. That's not a very favored explanation. So I'm not going into that too much. I think I've told you more than I really cared to. Environmental factors. So these are huge. The two biggest ones are the environmental and your diathesis stress model. Those are the two models that really are going to explain a lot where these disorders come from. So of course, we talk about, we talked about other disorders. We talked about how important the environment is, right? So histories, people who have a strong history of childhood neglect and trauma, probably not a big surprise there, right? So as of by now, we should start seeing that childhood neglect and trauma is pretty much the cause, or at least the exacerbator, for just about all of the mental health illnesses, right? Here's the other part too that we're going to talk about, which I find very interesting. Overexposure to the corticotropin releasing hormone. So this is that hormone that's part of that stress response, right? It's part of that CNS system. When we're under stress, like we talk about those fight or flight responses, and that corticotropin releasing hormone gets released, and then it releases this whole cascade of other stressful hormones that kind of amps up the system. So basically, the more people that are exposed to that stress hormone, the more that people are exposed to those stress hormones, there's more inflammation exposure, there's more stress hormone exposure, there's more exposure to hormones that actually contribute further to for the development of personality disorders as well. And of course, with those stress responses, those chronic stress responses, we start seeing other medical issues as well. The other one is that diathesis stress model, right? So, and this is probably the biggest part, right? So personality disorder develops from a combination of environmental factors, right? So we talk about that home life, the history of the home life, the history of trauma, the history of stability, and then those biological factors as well. And so this stress model balances both of those to explain how this happens. So it takes that personality trait and the temperament. So the idea is that your temperament, so your emotional reactions, right? So whether somebody's more, more chill, so whether somebody's more like relaxed or laid back for the most part versus somebody who tends to be kind of uptight. For those of us who have kids, right, we can kind of see that in our kids, right? So some of our kids are really like, okay, and then other kids, like my youngest, he's very like, he likes structure, when he's playing with his Legos, sometimes there's a big difference with my youngest. When he's playing with Legos, he's playing with Legos. But when he's building with Legos, it's like that's a whole other category. We're serious. We're building Legos. This is not playtime. And then his brothers, they're different. They're like, oh, come on, we're gonna be like Godzilla and crash everything. And so those temperaments that we have, and one of the things your book cites is that for the most part, those temperaments that we have as children kind of carry out with us for pretty solidly throughout our development and into adulthood. So basically, like I said, that it's a balance between those diathesis characteristics and then those the stress factors, right? So those physical stressors, those are the physical things that are going on in our lives. The social relationships, the social strains, the how we handle things among our relationships, and then our psychological factors as well. So between those two factors, those two main categories, whether or not when there's an imbalance there, whether there's an over imbalance with one and not enough combination or enough compensation from the other, that kind of explains where these personality disorders come from. So cluster A, you guys have kind of seen a little bit of this already. You've seen you've seen schizophrenia as a whole. For those of you who've had who've been to NAMS already, about half the class, just under half the class has had that experience. You can kind of see how with some of these eccentric personality disorders, you can see how there's a lot of schizophrenia in here. And as a matter of fact, you're going to see that I'm getting ahead of myself a little bit, but schizotypal, it's not entirely considered a personality disorder. That's more in the schizophrenia spectrum. So about 2 to 4%. So pretty prevalent, you know. The biggest thing with these is kind of, you can kind of look at the description. It's kind of self-explanatory, and especially if you know schizophrenia, you kind of can anticipate some of these characteristics of these folks. So this is a law. So for the main part, right, the biggest part is these folks, they have a long-standing, unrealistic level of distrust and suspicion. They don't trust people. They're always suspicious of everything. I'll give you an example of one patient. I met them the first time. So at the previous clinic, we lost 2 nurses. So we lost about half of our nursing staff. And so I absorbed one of the full-time nurses, one of their whole caseload. And one of the things I was worried about is that when you absorb that much of a caseload from somebody, you don't know those patients. And so, when I talk about how important that therapeutic and professional relationship is, in mental health, it's huge. And so this person was a perfect example. So I go out to the waiting room, and he was diagnosed with a paranoid personality disorder, not necessarily schizophrenia. And so I met him in the hallway, and you could just see it on his face. I mean, before he would even be willing to walk into the door to go into the back into my office, I mean, he had a dozen questions. Well, where's my other nurse? Did she get fired? Why do I have to go with you? Is there somebody else? Is there somebody else maybe I've seen another nurse here. Where are they? Can I see them instead? And it's like, okay, let's work this. I'm the only nurse here. I can help you. Believe me, I've worked with the other nurses as well. I don't know you, but I'd like to know you. But let's get the appointment started because we're running short on time this morning. And so, okay, I'll go back with you. And so, you could kind of see it like automatically, those little changes trigger these folks. And so we get to the back, and I go to take his blood pressure, and what? I can't take my blood pressure here. What? This is the hallway. What if other people see us? Doesn't this seem impersonal to you? I barely know your name. I don't want to take my blood pressure here in the hallway with everybody that can see. It's like, oh, okay, all right. Well, how about we do it in the room and we get carried on? we move on because we're losing time. And so basically, I had 45 minutes with this guy, and it was 45 minutes of that. So very unrealistic, very hyper vigilant. They're very, over anticipatory of hostility. So they think everybody's kind of out to get them. Um, so the biggest two things are those first two characteristics listed: that long-standing, unrealistic level of distrust, and that hyper vigilant, that just over hyper vigilance. That okay, somebody's out to get me. Something's wrong. Something's not right with the situation. So these symptoms usually apparent in childhood. They can arise in childhood. Social anxiety is a huge factor in childhood as well. It's something that folks will see. Um, often wise, and I've already touched on this a bit, is that this is often associated with schizophrenia. So for folks, for people who are seeing this in their kids, or people who are seeing this in adolescence or early adulthood, should start to get suspicious that there's some other component going on here. So treatment, it requires, again, just with all mental health illnesses and treating the mental health illnesses, to be successful, I talked to you guys before about how in other practices and in other specialties, for the most part, we can fix things. We can fix things for the patient, not to say that there's not a level of responsibility on the patient, or not to say that there's other things that the patient can't do. But for a lot of things, like we initiate things, the patient does them and they're fixed, right? So patient has high blood pressure, as a short example, we can educate patients how to fix that. Doctors can prescribe medications to fix their blood pressure. And then for the most part, right, it's handled. In mental health, it's mutual, right? This is a mutual effort. So it's not like we could just tell people what to do and their issues are fixed. It takes an active participation on their part as well. And this is where this is definitely one of these personality disorders where there is a huge amount of responsibility for treatment in the patient's lab, and they have to take that responsibility as well. And for paranoid personality disorders, it can be hard because part of the treatment is to start establishing a little bit of rigidity in their lives as far as stepping out of their perceptions of uncomfort. So when nurses and doctors and psychiatrists and whatnot make plans with these patients, they need to adhere to those strictly. If the patient makes a promise, or if they make an agreement that, okay, I'm going to take my medications, I'm going to arrive to my appointments, I'm going to come to therapy on Thursday, they need to be held accountable for those things, and they need to be called out when those things don't happen. Hey, we made a plan and you're not sticking to this plan. There's obviously a professional way to do that, and a kind and a compassionate way to do that. But still, that's part of the treatment for these folks, is that they need to be, there's a lot of accountability, basically with them kind of stepping out of those comfort levels a little bit. We need to be kind to them. We need to be professional, but we need to be neutral, right? We don't need to be overly kind with them. We don't need to be overly sensitive to them, because that's part of their issue. If you're too kind, their first instinct is going to be, well, why are they being nice to me? I don't even know them. Why are they being nice to me? What's the issue? What happened? What went wrong? So be nice, be professional, but we don't want to be too friendly with these folks. Limit setting for those threatening and aggressive behaviors. Just a short example with this patient, right? So we were using a telehealth model, delivery model for care, so which meant that our provider at that time was in Mesquite, which is in Southern Nevada, and that provider would telecommute, basically Skype or Zoom or whatever platform, Polycom, we would use to have them video conference to different rural clinics. I've talked to you guys about that before. So anyways, this particular patient, he was getting pretty angry about having to see somebody over the television. His previous provider was in person. And I had to say, look, this is what we have. Okay, I'm sorry this doesn't work for you. I'm sorry you're not happy with this, but you getting angry and threatening, that doesn't work for us. So if you're going to get angry and threatening, I'm going to ask you to go wait in the waiting room and either calm down, or you can pick somewhere else to get your services from. And so sometimes people have a hard time drawing those limits with folks, because we think that as nurses, we're just supposed to kind of roll over, and it's like, No, we can kind of draw those limits, and this is definitely one of those areas with some of these personalities, and especially some of the other personality disorders, where we kind of have to draw those limits because they need to know what those limits are. And there's therapeutic ways to do that. Look, I'm sorry this isn't working out for you, but you're being kind of aggressive right now, and that doesn't work for us. So treatment tends to be rejected. This is the hardest part with these folks. Um, as you can probably already anticipate already, well, you probably already think, well, how do you treat these folks? If they treat everything with suspicion and they don't want to follow through with things and they're always hyper vigilant of everything that we're telling them, then how do we get through to them? Exactly. It's hard. And it's not always as successful as we want it to be in our minds. Um, the biggest work is done in therapy, and that's only if patients are willing to engage in therapy. The biggest work that therapists do with these patients is to try to establish, a common reality with them. Look, man, not everybody's out to get you. Not everybody. You don't need to be suspicious of everybody. You know, so um, group therapy is typically not appropriate for these folks. If the treatment carries on and these folks, you do start getting a little bit successful, if therapists start getting a little bit successful with these folks, they might try group therapy because group therapy is a way for these folks to engage socially with other people. And it kind of helps them teach social skills about how to appropriately react to other people. But typically group therapy is not an appropriate early treatment for these folks. They need to be actively working towards addressing the personality disorder issues before you start talking about group therapy. If you throw these folks into group therapy early in treatment, they're not going to engage. Try to think about why that is. If it's not obvious for you why that is, definitely think about that. So some of the things that people can be prescribed for this, there's not for paranoid personality disorder. Again, we're not talking about schizophrenia specifically yet, okay? This is just for the personality disorder part. They might prescribe antidepressants to help with some of that social anxiety, they might prescribe some of the anxiolytics as well. Hydroxyzine they'll give, that's not necessarily a typical anxiolytic, but hydroxyzine's one. And then you guys have heard about the Ativans and the Xanaxes and the clonazepam. So those are some of the things to help with on the side for some of those accompanying symptoms. But typically, there's not a medication for. Typically, there's not many medications for personality disorders in general. So schizoid personality disorder. Again, I'm going to kind of try to breeze through this. You guys have seen a lot of the characteristics of these, and these are associated pretty closely with schizophrenia. So for folks who have a family history of schizophrenia, there's a stronger occurrence there. One of the biggest things with this schizoid personality disorders is that there's like this lifelong pattern of isolation. Like in high school, they might be seen as loners, or they might be seen as weird. Their behavior can be kind of odd. Sometimes they can be seen as like eccentric. They're kind of not necessarily flamboyant, but their behaviors are just very flavorful and uncharacteristic, just very weird. Usually symptoms appear early in childhood and in adolescence. So you can kind of see some of those schizophrenic characteristics here, right? There's that isolation factor. There's that odd thinking factor. This is one of the bigger parts too when it comes to these cluster A personality disorders, is this emotional detachment. So for the most part in these disorders, when these cluster A's, especially in the schizoid, and then the next one we'll talk about, there's just a complete emotional detachment. So they don't, as far as their emotional reactions to other people, love, affection, agitation, fascination, like they don't, there's a neutral bridge there. They don't feel those things and they're not affected by those things. So when people show affection towards them, they don't have a reaction for that. Their emotional reactions are very dull. So again, this is another one where we want to avoid being too nice or too friendly. Of course we can care, we want to be professional, we want to be nice, but you don't want to be too nice with these folks because again, it just kind of they already have a high level of suspicion. We don't want to push them away. Don't try to increase socialization with these folks. Again, those things are worked out in therapy, um, especially for the schizoid personality disorders. But we kind of have to work at the patient's level with this and where they're at. The problem with these schizoid personality disorders is that they're very chronic. They're very deep rooted, but don't try to force increasing this. We have to work at the patient's pace for that. One of the things with these schizophrenic-like personality disorders is that sometimes the folks are very hard to open up. I gave you an example of there was one male client that we saw, younger, schizophrenic, but there was definitely a schizoid personality disorder. There were definitely strong characteristics of the personality disorder with him as well. And one of the things was that even over 3 years, he was one of the only patients that I just could not break through this guy. There were 4 psychiatrists that we went through. I know it wasn't just me, um, even though it's fine. We can't fix everything on our own, right? But his biggest thing was that I know that there was other things going on in his head. I know that there were internal stimulus going on. I know there were thought patterns going on. I know that there were other symptoms going on there, and I know there still are. But this patient would not open up about what was going on. We've tried other nurses, we've tried other psychiatrists, and this person would just not open up. And in that situation, we did the best we could. We try to do the best we can to do a full assessment. And sometimes you'll get to those patients where they're just not going to open up to you. But the best thing you can do is to utilize those therapeutic communications, utilize that professional therapeutic relationship, some of those concepts that we've talked about, especially those of you who had the privilege to work at those in clinicals, and continue to build on those. That's the best way that we can get to try to get people to open up. Sometimes people aren't going to open up, but the best way that we can do that is to use those concepts. Like I told you in the beginning, I know they sound kind of hippy-dippy and they sound kind of fluffy, especially when we start looking at categorizing, some of those therapeutic skills. But I firmly believe there's a lot to get out of them. Some of you, I know you guys didn't get as much out of them as maybe you were anticipating, and other people have been using them. Some people have been using them in their settings where they work in the hospitals already, and they're seeing why they work. So this is a good example of that. Sometimes that's all we have is those therapeutic communication skills. Because these folks can be seen as kind of odd, because their behaviors can be kind of odd, even as nurses, sorry. Even as nurses, we have personal opinions too, right? And we'll see this and it's like, okay, we need to check ourselves. Remember that this is a patient. But in groups, right, we kind of have to protect these folks, in groups, when they engage in group therapy, especially if we're trying to work on increasing this socialization, right? If we're trying to work on that, again, the patient's pace, we do kind of have to protect the patient a little bit because the rest of the group, they may not be able to be as objective and professional as we are. So we have to watch these folks a little bit more closely in groups to protect them. So treatment, as with a lot of these personality disorders in psychotherapy, that's where we're going to see a lot of it, okay? The thing with schizoid personality disorders and even some of the schizophrenic disorders, they have a high level of introspection. They have a very high capability of self-reflection and evaluating themselves and how their actions and how their emotions are and how they relate to the world outside them. Again, this is one of the surprising things you guys have seen in clinicals is that just because somebody has some of these disorders doesn't mean that they're completely out of touch with reality. Like it's not like they're living for the most part. They're not living in a whole other world and they don't know what's going on around them, you know. And this is a great example. These folks, they recognize that and they have a high level of self-evaluation. And so this makes them actually a really good candidate for psychotherapy. Group therapy as well. Like I said, we touched on that, but again, at the patient's pace. This is where we start getting into the treatment with antipsychotics. Again, when we start talking about the schizoid personality and then we start talking about our next one, this is where we start seeing more of a close relationship with schizophrenia than we do with the paranoid personality disorder. So this is where our antipsychotics are going to kind of come into place a little bit. So we talk, you know, just to throw you a couple as far as antipsychotics, risperidol is going to come in here. Abilify will come in here. Aripiprazole is the other name for Abilify. So now we're talking about the schizotypal, right? Strong connection with familial history of schizophrenia. And again, I'm actually gonna try to breeze through this because this is more associated with schizophrenia than it is an actual personality disorder. Exceedingly strange, odd behaviors, disorganized, odd, unrealistic thinking patterns, right? That kind of screams personality disorder or schizophrenia, right? I mean, if we could add some auditory hallucinations into this, right? Or some visual hallucinations. How do you like my mouse drawings? If we got straight up schizophrenia, right? So, and of course, all the other characters kind of fall into place with this, right? So anxiety in social situations, rambling conversations, a lot of paranoia and mistrust and anxiety with engaging with other people. Look, there we've got our brief hallucinations and delusions, right? So schizophrenia, very closely related to schizophrenia. You know, so as far as our nursing guides for schizotypal, again, this is kind of very similar for it's kind of very similar to how we would address schizophrenia and even some of the other personality disorders that we've already talked about. We need to be aware and intervene, you know, appropriately with that patient's level of suspicion, right? Appropriately, right? So, you know, some of you guys have asked good questions about, well, how do I use therapeutic communication? You know, some of these patients are telling me weird things. I don't feel like I want to challenge them on it, but I feel like I don't know what to say. And it's like, you're kind of on the right track by saying, I don't want to challenge them. You know, I don't know what to say. You know, with some of these folks, you don't want to challenge them. You know, they're living they're living with this, right? This is their reality for the most part. I mean, of course it could get better, and of course, you know, they can accomplish things, and of course that these are people, you know, these are patients, we want to respect them, but they're kind of living in this reality, right? And so once it starts going into those areas where, all right, this is kind of a safety issue. This person's not taking care of themselves now. I don't think this person is safe by themselves. I don't think this person is safe for others. You know, that's, you know, I feel like, or you know, even Mario has touched on this as well. You know, when their suspicions and behaviors are kind of escalating themselves, you know, like, so like if somebody sees those spiders or they see those things or they see those things on the wall that aren't really there and it's activating them, right? It's like, no, those aren't there. Look, let me show you. Those aren't there. Okay, that's not real. You know, hopefully that makes sense to you guys. But if not, we can discuss it, right? Again, we need to withhold those judgment and ridicule. I kind of feel like that goes without saying. So treatment. All right, this is I meant to investigate possible involvement with cults. I meant to actually take that off to be honest with you, just because it was like, it just seems like a really specific and kind of almost like an outlier, right? But either way, I guess if your book says that, your book says that. Low dose antipsychotics, right? So that big shocker there, right? So psychotherapy and low dose antipsychotics. So now we're getting into the cluster Bs. So these are the fun ones, okay? Remember, again, I said it a dozen times already that, you know, you're going to see a lot of these mental illnesses in your professional settings, no matter where you're at. And these are definitely them. I guarantee you, you guys have already seen these in your personal lives. You've seen these in the public. You've seen these, you've seen these among friends, among family, among wherever. I don't care who you are. You've seen these before. And I don't mean to sound demeaning. I don't mean to sound criticizing at all when I say that. It's just a reality. These cluster Bs, they are so prevalent. Um, I don't know if I'd ever believe if any that nobody's seen these in one form or another. So Jim and Meredith, they got this. They're going to counseling together to save their marriage. I don't know why it says Mercedes there. That's really silly. So anyways, therapist quickly notices that Jim's he thinks a lot of himself. Um, he's talking about himself a lot, and then when Meredith expresses anything such as hurt, um, he's got some kind of criticism for that. Therapist notices that Jim frequently boasts about himself, um, as if he's kind of seeking admiration, right? Um, to for those of you familiar with some of these, we'll call it, disorders, you probably already see where that case study is going. It's not histrionic, by the way. So histrionic, right? We've all seen this behavior. The big thing that we see with histrionic personality disorder are kind of these two things, and these are the things that kind of drive us nuts, right? Their behaviors and their actions are very bold, right? So when they're frustrated or when they're happy, they're very bold, and they're very their actions proclaim their feelings about these things, right? So you know, very attention seeking, very kind of self centered with these folks. We'll use the supermarket example, right? So you go to the supermarket and, no offense, I'm just using the mom, okay? All right. It happens in males, it happens in females, but I'm using the mom as the example, all right? So mom's in the supermarket, right? And, they have a child with them, and the child might do something like really minute, right? Like grab the apple off of the counter without asking, right? And so mom gets frustrated and starts kind of yelling, so that everybody can hear, you're not supposed to do that. There's the coronavirus. You shouldn't be doing this. How many times have I told you? And so there's this big outburst, and she wants everybody to hear that she's scolding her child because, to make everybody think that she's thinking about everybody else, and she's trying to bring this attention to herself, right? So that can also be seen as, that example also kind of translates to borderline as well, but that's kind of what we think about with histrionics, right? It can be very controlling. For example, for folks, a little bit different example, right? So for kids, right, when parents use that against their kids, right? Let's use an extreme example, right? Like the kid wants to go play at the playground, right? And the mom or the dad, they might have their own issues of themselves. They might have this personality disorder, and they use their emotions, right, to manipulate that kid to not want to go to the playground. Oh, fine, I'll just do all these chores by myself. Fine, whatever it is. So they might use those bold external, like overly reactive reactions to kind of manipulate the situation to get what they want. So you can kind of see that the real key characteristics of histrionics, and I apologize, but some of those behaviors that I'm giving you as far as examples go, those go with borderline as well. But when we're talking about histrionics, there's this bold external behavior, very, very flagrant, very just very bold external behaviors, right? They want people to see. That's the big part. The attention-seeking part with the low frustration level, that's the big part. And then the excessive emotions. And those excessive emotions can kind of go both ways, not just with frustrations, but with being provocative and flirtatious as well. So those kind of three things right there, those are the big key points when we talk about histrionic personality disorder. These folks, You know, as with a few personality disorders, they typically don't think they need help. I kind of touched on that a little bit of how that can be hard to treat somebody, especially when we talk about, excuse me, I'm sorry, especially when we talk about how the burden of responsibility for treatment is in the patient's lap as well. You know, well, Robert, what are you saying? How do we treat these folks if they don't feel like they need help? Then if you're asking that question, then you're already kind of seeing the difficulty with treating it. These folks, they kind of have a shallow level, a very limited level of self-reflection and introspection. So their ability to reflect on how their person, on how their emotions and their reactions and how their presence is interacting with the environment is very limited. So treatment, psychotherapy is really where the rubber meets the road. This is where a lot of the work is happening. The focus with therapy on these folks, because the focus with therapy is on clarification of their inner feelings versus expression. Some of you guys have asked really good questions about, well, what does therapy look like? Like, what are some of the questions? What are some of the areas that the therapists work with on with some of these folks? And I thought that was a really, really good question, because when we talk about therapy, you know, that's kind of where nursing ends, right? Nurses aren't engaging in therapy. You know, we're not licensed therapists. We're typically not licensed in social work and whatnot. So we don't do, you know, we don't do the therapy with these folks. You know, our relationship, our sorry, I'm having a hard time finding my words, but basically our role is kind of ends there, right? And so some people were asking what that looks like. I thought that was an excellent question. So that's why that's why I left some of these in there for you guys, because I thought that would be beneficial. So anyways, the focus is basically getting these folks with these personality disorders to process their inner feelings. All right, how is it in that situation? What did you feel in that situation? Right? Well, my kid, I got frustrated because he shouldn't have grabbed that apple. Okay, well, do you feel like that reaction was what other people around you, how they would have reacted? How do you feel like you should have reacted? You know, do you feel like you needed to react in the way that you reacted? Right? So it gets people to kind of think about their reactions and their feelings and how they're affecting the people around them and the environment around them and the reactions that they can expect. So it gets people, it's a long process. This is a very long process to get people to open up and recognize those things. Um, Group therapy, again, for these folks, group therapy, again, this is another one of those personality disorders where it could be appropriate. It just depends on what their reactions and their behaviors are. If they're very histrionic and and their biggest issue is trying to get reactions and trying to get the attention of everybody, if they're trying to get that affirmation from other people, they need to be checked. So for nursing care, right? Gotta watch that seductive behavior. That goes for both, whether you're a male nurse or a female nurse. Histrionics are typically more prevalent in females, I believe, but still, I mean, that doesn't no personality disorder is isolated to any one sex, gender, ethnicity, culture, right? Interactions need to be professional, right? If for those flirtatious actions from patients, those need to be ignored or checked. Hey, you know, I'm a nurse, I'm your nurse, I'm here to help you. Those flirtations, we need to avoid those. Those can't happen here. Help the patient clarify those inner feelings, right? Hey, so you seem like you're really anxious, or you seem like you were very agitated, but you really think you meant to feel as anxious as you were, or you really feel like you meant to feel as angry as you were. Help patients kind of work through that a little bit, and then again to role model that assertiveness as well. You know, again, sometimes nurses, you know, that's the hard part where some of us have struggled in the past, where it's like, well, I'm a nurse, I'm not supposed to be assertive, right? And it's like, yeah, you can be. And personality disorders are definitely where you're going to get that workout. So Jim and Meredith are continuing to work, right, and therapy. Um, Sorry. Sorry about that. There's some kind of nonsense going outside the window, and to be honest with you, I didn't want to really mess with the recording too much because I was afraid I'd lose everything. So, anyways, going on. So Jim and Meredith are in therapy, right? And the therapist quickly learns that Jim, he's not really interested in changing, right? Um, Meredith, Meredith and Jim, they're kind of both financially successful, except Jim manages everything, and Meredith feels like Jim is pretty exploitive of her. Um, Jim's also pretty hypersensitive to criticism. Um, he's the smarter person. He's entitled. Um, so Jim's kind of a jerk, right? So narcissistic personality disorder, right? So say hello to Jim if you haven't figured that one out yet. Um, so these folks, this is definitely, remember I mentioned earlier, there's still a sense of accountability with these folks, and this is definitely one of them. Um, these folks, if you're not familiar with narcissism, and I'm sorry, I shouldn't assume that everybody's been exposed to some of these personality disorders. Um, the reality is, I think you have, it's just you don't know how to classify them. And so, I apologize for making that, you know, for making that assumption for some of you who aren't able to identify the specifics. Okay, so narcissism. These folks are really entitled. They have we talk about spectrums of normalcy, right? So on a spectrum, most of us have, an evaluation of ourselves as far as how important we feel we are, right? Some of us have a healthy level of self-esteem, right? Where we feel important, we feel valued, and other people not so much. But there's a spectrum of what's normal, right? These folks are complete. They blow those normal levels out of the water. Their self-importance and their self-value is completely exaggerated and overinflated, and it's really not in line with reality. Um, so they really feel highly of themselves, more so, which is completely exaggerated. They have a lack of empathy towards other people. Jim's a really good example. They have a tendency to kind of exploit others and to manipulate other people to get what they want. But at the same time, there's definitely a strong sense of there's a weak self-esteem there. So their level of self-value, even though they verbalize, uh, even though they verbalize and they display this exaggerated self-importance, their self-esteem is kind of sucking. And they're very hypersensitive to criticism as well. Um, they have this constant need for admiration. They have that constant attention seeking behavior. They want affirmation and admiration from other people. Um, but at the same time, these folks are pretty functional. So compared to other personality disorders, such as like some of our dependencies, um, some of the schizotypal types, these folks are, for the most part, they're pretty, as far as their level of functioning in society, it's pretty normal, outside of the relationships and whatnot, right? So, big shocker, right? Um, Again, start thinking about what interventions would you predict to be most helpful in working with Jim. Um, so, guidelines for nurses, right? We got to remain neutral. So, some of these folks, I'll give you another example. So, the last person I had was a female. She was mid to late age, so late 50s. Her main issue was She was narcissistic. That was her personality. That was her disorder for treatment. That was the only thing that we had diagnosed her with. She was not bipolar. Um, she wasn't. She didn't have some kind of PTSD. She was straight up narcissistic, and that was definitely one of the most challenging patients that I've taken care of. I had a 2-year relationship, professional nursing relationship with this person, and it could be pretty exhausting. I had to remind myself to stay neutral. This is one of the things that I would actually physically tell myself. All right, this person's coming in. Robert, don't react. Just do your job, do your thorough assessments, engage with them in the areas that they want to engage with today, as far as, um, as far as, um, where they want the treatment to go, where they're hoping the treatment to go. Because this person in question, they actually were pretty high functioning. And they actually had a pretty high level of self-reflection as well. They knew they were narcissistic. They called themselves narcissistic. Um, they would recognize behaviors. I mean, this person was nasty. I mean, this person was nasty. The last story I remember hearing was that this person was in the supermarket, and they were in line with a shopping cart, and the person in front of them had backed up a little bit and didn't see the patient standing behind them, and they kind of bumped carts a little bit. And the um the comments and the things that this patient was yelling at this other lady, I just couldn't I just couldn't imagine being there for this other customer. They were horrible. This patient tore this lady down, and but she recognized it. She says, I tore her down, told her a bunch of things I probably shouldn't have said in the public setting, but you know what? She's an idiot, and she gets what she deserves. It's like, okay, you know, these people can be rough, and as a nurses, it's okay to be like, okay, well, do you think there's maybe a better way to handle that? Do you think maybe there's a better way that could have um, you could have reacted to that situation? How do you think the other person felt? And that's what I asked her. I said, well, that seems like it was a pretty strong reaction. Do you really think that was necessary? And her answer was no. No, it wasn't necessary, but I don't care. So um, so it kind of goes into that avoiding power struggles with these folks, right? Um, obviously internally, I had a pretty strong opinion about how I felt with that reaction, how she treated that other person. Um, but you know what? You have to remain neutral, and you got to avoid those power struggles, because you're not going to get anywhere. Um, the best you can do is kind of role model those behaviors that you hoped that they could see. The best thing you can do is to give examples, and to kind of try to remain professional. Because you get in those power struggles with these folks, you get in those power struggles with just about anybody, you're not going to go anywhere. But especially with these narcissistic folks. These folks, as you can imagine, very difficult to treat. These patients, they are not likely to seek help or confront their shortcomings on their own. The example with Jim and Meredith is actually a really good example. Jim is not there because he feels like he needs to be there. Jim did not initiate this intervention. Jim is only there because Meredith is making him go there. CBT can be effective with these folks if they engage enough. Again, it's all about reframing those thoughts, reframing those thought processes. Sometimes moods can be a little bit of an issue with these folks too, when they get those mood swings and whatnot. So lithium and other mood stabilizers too. One of the things about your text, it mentions only lithium. I disagree with that. There are other mood stabilizers as well. For testing purposes and for this purpose, of the lecture, I'm going to stick with lithium, okay, or just mood stabilizers in general. So don't get too wrapped up in the medications. So we're getting into antisocial a little bit. Antisocial, this is one where, we talked about those impulse disorders last week. We talked about especially conduct disorder and oppositional defiant disorder. This is probably going to be the area where some of you get a little bit frustrated, because you're going to be like, dude, this sounds like the same disorder. And it sounds like we're talking about the same things. And I get it. There's a lot of overlap, and there's a lot of overlapping characteristics with some of these. Okay, but try not to get too frustrated. The main characteristics of antisocial behavior is this antagonistic behavior. They're really looking to push people's buttons. They're really looking to get a rise out of people. They're really looking to get a reaction out of people, and they're doing it on purpose. They're doing it for some kind of purpose, for their own personal pleasure. There's a lot of deceit with these folks, a lot of lying and manipulation to get what they want out of a situation. They'll manipulate people to get what they want. High risk taking behaviors, right? They're kind of impulsive, right? Kind of related to those impulsive disorders, right? And a complete disregard for their responsibility. There's no accountability with these folks, right? So you can kind of use that to think about examples for like criminal behavior, right? So what? It doesn't matter to me. Those rules don't apply to me. Again, very similar to ODD and conduct disorder as well. The biggest thing with antisocial personality disorder is that there is that manipulation factor is very strong here, and the antagonistic behaviors are very strong, and that that kind of disregard for responsibility. Those three factors right there, right here, those are the biggest strong factors with this. They're intentional. Okay, with ODD, even conduct disorder to a certain point, they're kind of impulsive, right? They're kind of doing these things for the most part without thinking about them. Antisocial personality disorder, a lot of this is premeditative. They know what they're doing. They're thinking about it. They're intentional in what they want to carry out. And of course, kind of similar to conduct disorder, there's a profound lack of empathy. They don't care. There's no guilt. There's no remorse about their actions. They're intentional about it. So if you want like a famous example, Charles Manson was probably, I didn't Google it, but maybe I will. I got my phone here, right? Charles Manson, a lot of his behaviors remind me of antisocial personality. So to carry on a little bit, and I'll come back to you. So assessment, right? So again, a lot of deceit, a lot of lying, manipulation. So your assessments, during your assessments, you may or may not get the truth out of these folks. As far as your self-assessment, because of your self-assessment, you don't want to exhaust yourself at the expense of these folks. Again, remain neutral. Don't get in those power struggles, right? This is definitely one of those disorders where there's an accountability level on the patient's part as well. So you expending yourself, you getting frustrated and working out your frustrations and working out your anger vocally, you're breaking those professional lines, you're not doing anything but hurting yourself. So as you could probably tell, I'm kind of just basically Googling this, which is, take it with a grain of salt, right? But according to the Pennsylvania State University, they think Charles Manson was antisocial. He had psychopath tendencies, and there was definitely some kind of paranoid, delusional aspects to him. But antisocial is definitely at the top of the list for some of his issues as well. So, but not to say, and I should back up a little bit. Not to say that everybody with antisocial personality disorder is going to be like Charles Manson, right? I mean, there's spectrums, right? Like as with any illness, there's a spectrum where somebody's got a little bit of an issue and somebody's Charles Manson, right? So, but it gives you a little bit of an example, right? So with the nursing diagnoses, right, you guys think about some of these things, some of the issues these folks have. You can kind of come up with these nursing diagnoses on your own, right? I mean, defensive coping, right? Especially with those narcissistic folks. Impaired social interactions, right? Risk for other directed violence, right? Even self-directed violence. So some of the outcomes we want to see, right? Especially with antisocial personality disorder, right? Again, if we're identifying the problems, which you guys should already kind of be doing on your own at this point, you identify some of the problems associated with this. The outcomes are going to be directly related to your problems, right? So with Jim, right, we want to see some like self-restraint with his manipulation. We didn't see any, abuse in the case study, but he's controlling, he's unrealistic, right? So, and there's obviously he needs some self-restraint, right? Coping, social interactions, social isolation, right? Health promotion, health promoting behaviors, right? Having those folks as far as promoting healthy behaviors, right? Um, right, increasing that introspection, right? Increasing their knowledge of how they evaluate themselves, how they evaluate how their reactions, their emotions, their presence is affecting other people, right? As we've already touched on, it's going to be pretty difficult to accomplish with some of these folks, okay? Again, some of these are kind of already intuitive, and a lot of them we've already kind of touched on a lot. So boundaries, consistency, and limits, right? Realistic choices for these folks. Realistic choices, and realistic decision making mutually between yourself and them as well. Again, there's a level of accountability with some of these folks, especially with antisocial, especially with narcissistic personality disorder. Um, you know, when you're making when you're having that mutual decision making process with these folks, it's got to be realistic, right? Don't set expectations that you want for the patient that they're not capable or not wanting to carry out for themselves. As far as long-term, this is the other part that I thought was kind of interesting too. As far as advanced practices, as far as long-term treatments and whatnot, um, these folks rarely stick it out. In the example of the lady that I was telling you about, she'd been established in that health for quite a long time. So that example is kind of one of the outliers. That's not very typical. So borderlines. So this is the most well-known. Um, most of us have seen this. Um, most of us have plenty of firsthand experience in this, whether inside nursing or outside of it. These folks, it's characterized by a complete lack of emotional control. It's not really to be confused with mania, although we'll kind of talk about that a little bit. Actually, I'll probably go into that right now. They can be kind of impulsive, a lot of self-destructive behaviors. They see it as soothing. They can see it as relieving measures. So risk-taking measures. One lady, seemed like this lady was always getting into car accidents. And that's because we think that her self-destructive behaviors really came out when she was driving. It's kind of scary, right? But other behaviors as well. So they'll resort to cutting. They'll resort to sexual promiscuity. Substance abuse, a strong suicidal ideation history. They could also be very antagonistic, kind of very antagonizing people, trying to get a rise out of people. And all of this boils out to trying to manipulate the situations. This all adds up to trying to either manipulate somebody or something to get things to work out how they want them to work out. This isn't necessarily, I say this cautiously, this isn't, like with some of the antisocial personality and the narcissism, that's very intentional. We say there's a level of intent with those. With this one, that level of intent is less. These behaviors, they come out of like poor coping mechanisms, right? They come out of childlike and poor coping mechanisms to adapt to get what you want. So if you think about it, like um, we think about some of these behaviors, like antagonizing somebody, right? Like something like children do to get what they want, right? So like if they want their brother or sister to do something, they might tease them or antagonize the situation to kind of get what it is they want. And for these adults, they kind of don't grow out of that. Talking about mania real quick, okay? This is why I've touched on this a little bit, and I am absolutely 100% completely convinced. And I've talked to psychiatrists who feel the same way as well, that a lot of times people will be diagnosed with bipolar disorder when in fact they're really just borderline. And let me tell you why that is. It's because a lot of there's this factor right here, this emotional, they don't have control of their emotions, right? Which you can see can kind of look like mania, right? So you have this unregulation of their emotions, And then you have all the ramifications, right? If you look at all the ramifications of some of these things, right? Right, you look at the ramifications of impulsivity and the ramifications of self-destructive behavior and antagonism, right? So these folks can't really hold a job very well, right? Their relationships are completely destroyed most of the time. They can't keep a real solid relationship unless it's, I mean, they can keep relationships, but they have a hard time doing it, right? And those are the same characteristics, those are the same ramifications of folks who have long-term chronic bipolar disorder, right? So that's why a lot of the times you'll see, well, man, I don't think this person's bipolar. I think they're borderline. And I've seen it plenty of times where these bipolar folks, they run out of their meds or they stop their meds, or even folks, they just don't want to be on meds anymore and they completely come off of their meds and there is no change in behavior. There are plenty of folks at the last clinic I came from where um, they would stop their meds or we would stop their meds for one reason or another, right? All the choices are made individualistically and no behavioral changes were seen, right? And that is because they weren't bipolar, they were borderline, right? So um, I'm not going to expect you guys to like know those things on the test, but I just want you to kind of think that like, basically what I'm saying is I'm not going to ask you to distinguish, between borderline and bipolar on the exam, okay? But it kind of gives you guys an example of why we need to appreciate the differences between the disorders, but it's at the same time kind of understand that there's a lot of overlap and there's a lot of room for interpretation. So splitting, I have talked about splitting before with you guys, and I was kind of waiting till now to give it a more firm definition. This is kind of splitting is very unique to borderline patients, and basically, to kind of put it in a nutshell, these folks have this black or white thinking. Now, I know we all have some form of black or white thinking, right? Like in areas of our lives, we have black or white thinking, but this is the person where everything is black or white. Either you're a good person or you're a bad person. Either you're doing the right things or you're doing the wrong things. And that translates to every one of their relationships. And um, this is why in the professional relationships, in their social relationships, in their intimate relationships, things fall apart. Is because initially these folks will see the good, in most relationships, that's how it is, right? We see the good in people, right? But as we mature and if we're engaging in our relationships in a healthy way, we start seeing some of the more negative things or some of the things that we don't quite care about in other people, right? But we have a healthy way to process that, right? We start valuing people as the whole person, as the whole people they are, right? Nobody's perfect, and we learn how to appreciate that. With these folks, their relationships are pretty shallow because initially they will see the value in people, right? But then as soon as they're disappointed, and as soon as things go wrong, now you're an enemy, and now you're not good. And they throw those things out, right? And they get then all of a sudden now you're casted into that other side. And so this kind of translates into all their relationships, right? So as the example, right, that I kind of told you guys before, you know, but I'm gonna actually kind of keep it short. But basically, for one patient, I was the best nurse there was, you know. And whenever I hear that, I tell people it's like, no, I'm not the best nurse. I'm glad you think highly of me, and I'm glad I'm doing a good job for you, but I am not the best nurse. And please don't think that, you know. But oh man, Robert, you're just the best nurse there is. I think you're the best nurse in this clinic, and I think you have a lot to teach these other nurses here. And it's like, hmm, okay. But the minute that patient didn't get what they wanted from me, the minute that patient wanted something that they knew that they weren't supposed to get. In this case, I told you the example of the patient who had two psychiatrists and they wanted us to prescribe their meds, right? Now I said no, and all of a sudden, and this is their words, I was the devil. She thought I was the most demonic nurse she had ever met in her life, right? So things are great initially, but as soon as I tell her, well, no, we already came up with a plan. Remember, we told you no. Now I'm the devil, right? And that's how that's what splitting is, and people use that for a number of different reasons, but one is for again, a poor coping mechanisms for themselves. They're confronted with a situation they don't want to deal with, right? They don't want to deal with that rejection. They don't want to deal with that accountability. So in a childlike way, they cast you off into that you're a bad person category, and now they don't have to deal with you anymore, right? So it's their defensive mechanism for not having to deal with the situation. But they also do it too. One of the other reasons is to manipulate. Because the other part of that situation is, well, I've cast Robert off now. He's a bad person. I don't have to deal with him. Now I'm going to go to the other person, my service coordinator. I know I want you to know that, Robert, he's treating me bad and he won't give me my medications. And I'm really hoping that you'll help me out. Right. So now this other person is idealized, right, to try to manipulate them to get what they want out of the situation. Hopefully that makes sense to you guys, and hopefully that gives you a clinical picture of what splitting looks like and why they do that. But ultimately, it's a very childlike and immature behavior. It's an immature coping mechanism, and I don't say immature like in a demeaning way. It's just it is. It's an immature reaction according to their maturity level. So prevalence. Again, so 1.6%, so close to 2%, right? Again, if we go to, if we use the supermarket example, right? You go to Walmart or Target or wherever on a busy day and there's 50 people, 60 people, you're going to see one or two people that have this, right? Give or take, right? 85%. Look at this. This is huge. And this is why I say that you are absolutely going to see this. And this is why there's such I try to get that, you guys think about that picture, how there's a kind of a big overlap with things. 85% of bipolar, or not bipolar, of borderline personality disorder patients, 85% have some other mental illness. It's kind of crazy, right? So as far as where it comes from, it's very highly associated with first degree relatives. So mom, dad, brother, sister, right? If they're borderline, chances are it's going to keep going down the line. Also comes from this, I'm not going to go too deep into this, but the separation individuation factor is that there's a model, that your book describes, that going from infancy to toddler to child, right? There's a healthy level of physical and psychological attachment to the mother, right? So initially, right, the infant is attached, right? Or the significant other, right? So because we have dads that are strongly involved, right? We have, same sex families, right? Like we have all kinds of different pictures of what the family looks like. But so initially, right, there's the infant is physically and psychologically attached to the mother, and then there's a healthy progress of separation, right? So eventually the child detaches both physically and psychologically, and there's more independence that grows, right? And there's a healthy way to do that. Borderline personality disorder, one of the strong factors of where they think this comes from is a disruption in that. Right. So let's use, I think it's the example your book uses. I think it's a good example, right? So mom is starting to attach from the infant, right? And the child wants more independence, right? And so a healthy way to do that would be for the mom or the dad or whoever, right? To foster that independence, right? But instead of fostering the independence, right, that significant other kind of manipulates the child. Well, you go ahead and play with your friends. I'll just be here by myself, right? I have all these things to do, but I'll just do it by myself. You go ahead and play, and I'll just kind of be by myself, and I'll just suffer alone, right? So when kids are exposed to situations like that where they feel manipulated, or like they feel like they have to regress back to that physical dependence, right? And that physical and psychological dependence, that's where these personality disorders have a strong factor of developing. Don't you just love my straight lines here? Structured interviews with these folks, right? So A lot of times when you're interviewing and doing your assessments with these folks, it's easy to get on a tangent, especially when we're doing full psychosocial assessments on these people. You know, they'll find reasons to kind of talk about other things outside of the assessment or bring attention to themselves on other things, and you have to keep to that structure. Okay, I understand those things are important to you, and I'm sorry, but we have a limited time, and we have to go through these subjects in this interview. Okay, we have to stay on track. Um, I am drawing a total blank, and I'm sorry. The MMPI. This is the basically this is the assessment scale for assessing like mood disorders and whatnot in folks. Um, and you know, there's lots of different scales, and basically they all kind of categorize, or they all kind of help you assess. I don't want to say the same things, but the important things, right? So, as far as their abilities to regulate moods and emotions, uh, you assess areas of risky behavior, right? As far as substance abuses and promiscuity and other self-harm and other directed harm behaviors. The intensity of feelings. There's an intensity of feelings scale as well. Because with these folks, there's obviously we talk about that emotional imbalance, and their intensity of feelings can be way more pronounced than it really should be, or what is considered normal. How they ideal a scale for how they idealize relationships, right? So we talked about how things are always black and white, right? And how do they see relationships? Well, either you're my friend or you're my enemy. There's nothing in between, right? It's like that's that's not realistic, right? Some nursing diagnosis, right? So self-mutilation, that's kind of a big thing, and risk for suicide. Again, some of you guys already know where I'm going with this, right? But there is a strong factor when we talk about attention seeking and manipulative behaviors. Okay, and I've already touched on this before. Borderline personalities, they use what they can to manipulate people to get what they want, right? So whether it's cutting, whether it's threatening suicide, they will absolutely do those things. That should make absolutely have whether or not you think those behaviors are serious or not, whether you think they're just looking for attention, you know, whether oh they're just borderline, they're just feigning suicide one more time, and I'm not buying into it. Yeah, you kind of are, because you know what? No matter what we think the threat is, no matter what we think no matter what we think of the personality disorder, we treat all of these threats the same. But I've already touched on that. I'm not gonna. I'll leave that alone. So outcomes and planning again. I'll have you guys kind of go through that. Um, some of the things we want to see with these folks. You know, what is it? Whatever the outcomes we want to see. Um, you know, how are we going to measure that? As far as implementation, again, what are we doing as nurses? You know, some of you guys want to know, what do I physically do to deal with this person? Again, a lot of the work with personality disorders is done in therapy. Okay, and the best thing that we can do is reinforce what it is, the behaviors we want them to see, and reinforce their engagement in therapy, and reinforce the rules and the structures. Okay. As far as nurses go, I don't want to say there's not a lot that we can do, but we could definitely we could definitely support the system, and we can definitely support the overall process. We do that by being straightforward with our communication with them. We be honest about what it is they need to do. We set clear and consistent boundaries with them. Um, and of course, we work with the whole team, right? So one of the things um, that was surprising out of that one situation I told you about was that the caseworker automatically assumed and went and thought that I wasn't doing my job. Uh, Personally, I found that very frustrating, because, you know, for those of us that work in mental health, we know that splitting behaviors come out quite often, and that our first reaction is to come together and to assess the situation before we react. And for me, that was very frustrating, because that didn't happen. The first thing that happened was that they assumed that Robert wasn't doing his job. And so automatically you can already see how that would be a big issue for the team, right? When somebody is using that splitting behavior and it's affecting the team. So everybody needs to work together. Everybody needs to be on the same page, and the communication needs to be open, right? If you have this goes into all kinds of other factors as well. I firmly believe that if you have a problem with somebody, your first action as long as it's safe and as long as it's not something that has to do with like something serious like sexual abuse or stealing medications and whatnot, if you have a problem with somebody and it's on a person to person level, right? I strongly believe that your first responsibility is to talk to that person. And it's the same issue here. That translates to everything. Talk to your team, be open and honest, and have that professional communication with them. Again, respond matter of factly to superficial injuries. Again, that's some of those things that we're gonna. Most people are gonna have it, you guys. That's just borderline. They're just looking for attention. All right, that may be, but there's a matter of fact and professional way to address it. Okay. So as with some of the other personality disorders, again, there's no specific medication for this. We'll prescribe other psychotropics to help with some of the other accompanying symptoms with it. So if depression is really prominent in these folks, if anxiety is really prominent with these folks, if they need a lot of help with that mood stabilization, that emotional regulation, we'll use medications. So SSRIs like our Zoloft, Lexapro, those are the two, sertraline and escitalopram, that's the other names. Those are the two ones we'll see the most. The mood stabilizers, probably lithium and Lamictal. You'll probably see those the most. So again, this is, I skipped ahead there, I'm sorry. Because of the way the slideshow works, it won't let me go back. But as far as some of the treatments go, there's a strong emphasis on CBT. We've already talked about CBT, but DBT is a very, very strong emphasis for borderline personality disorders. And that is because there's that emotional aspect, how their emotions and how their reactions are, how they're displaying those to other people, and how their presence and their emotions and their interactions are interacting with the people around them and their relationships and whatnot. And with DBT, there's a very strong component of that. So avoidant personality disorder, right? This is one where this is very strongly associated with low self-esteem and shyness. And as they age, that shyness only gets worse. They used to use a term a long time ago called an inferiority complex. I don't know if they still do or not, but this is kind of characteristic of that, right? These people feel less than other people. Their self-esteem is really low. They have a very low threshold for self-esteem, right? They're very highly preoccupied with rejection and humiliation. So we want to be friendly and accepting and reassuring with these folks, right? We want to be compassionate and kind to them, okay? Not to be confused with coddling, but these folks, they're really damaged. They have a lot of self-esteem issues, a lot of self-value issues, so we want to be accepting and kind to them, right? We want to accept their fears, right? Their fears are going to be a little bit more pronounced than what we may think is realistic, right? So we need to be accepting of that. Group therapy can be good for them, okay? Again, generally, and in general, I say this in general with most things, group therapy is typically not a very good initial treatment option. It's usually once people have been established in therapy a little bit, and then you move on to group therapies, and this is definitely the case here. There's also a strong focus on enhancing the social skills. So one of the things with these folks with avoidant personality disorders is that they have this really low self-esteem and they have this low self-value. And you'll find that with these folks, they typically have friends that are much younger than their age. They'll usually make friends who are, especially when we're talking about school age children, or teens or adolescents, their friends, people they consider friends are much, much younger than they are. And so part of the treatment for these folks is getting them to engage a little bit more appropriately socially, getting them to engage with people more their own age. A lot of assertiveness too. Again, they can have that avoidant kind of dependent personality where they don't kind of stand up for themselves or they don't advocate for themselves. And the therapy approach for them is to get them to kind of step outside those comfort zones a little bit by being a little bit more assertive. Again, this is one of those areas I thought was kind of cool. Some of the students, some of you guys, kind of think it's really neat to see some of the other medications used for things that you wouldn't think of, or the things that you don't automatically think might help. Beta blockers will help with the hyperreactivity. Some of these folks can be kind of hypervigilant. They can be quick to react to negative stimuli, to negative criticism. They can get really anxious really easy. Beta blockers help suppress some of those reactions a little bit, help some of those automatic responses slow down a little bit. And then SSRIs and SNRIs, they'll be used to help with that social anxiety. Cymbalta for the SNRI, that one's used quite a bit. Your SSRIs, Lexapro is favored quite a bit. Escitalopram, that's the other name. Um, and again, Zoloft as well, sertraline. So if you haven't caught on yet, Zoloft and sertraline, they're pretty popular in the prescribing practices now. Those two antidepressants, they're very tolerated. The side effect profile is pretty low, and the indications they got a lot of room, a lot of areas where they can work in pretty well. Of course, it's not a free lunch. They have their issues as well, but for the most part, um, Lexapro and Zoloft, they're pretty popular. And this is another one of those areas. So this is dependent personality disorder. So not necessarily the same as avoidant, but you could kind of see a little bit of similarity. These folks are highly submissive, very clingy, very dependent on, on their significant others or on the people they have relationships with. They have a very intense fear of being separated or abandoned. Um, I'll use this as an example, although it's not a dependent personality disorder. When my wife was pregnant with our middle son, I remember she was so emotional, in that third trimester. I remember she would stand at the front door and she would literally beg me not to go to work just to hang out with her for the day. She would get so lonely being at home by herself, and she would cry and she would beg me not to go to work. And of course there's pregnancy hormones and there's all kinds of stuff going on, and of course, as a decent husband, there are days that I stayed home with her, but these types of folks, they have those reactions, right? Like they use their emotions and they use their anxieties and their frustrations to manipulate people to get what they want in their relationships, right? If we look back to that child mother example I was telling you about, how, well, the child wants to go play, right? Well, the mom or the significant other or the whoever it is, the parental unit, might have those overreactive emotional responses to try to manipulate the situation to get what they want, right? Because they don't want that child to go or child to leave, for whatever reason that is, right? They might do that to their husbands or to their wives, right? People might do that to their friends, to people who to try to get what they want, right? Um, these folks, they have a very high sense of insecurity. These folks are very, very insecure. So for these folks, again, as with some of the other personality disorders as well, or even the avoidant one, be aware of that strong factor of transference and counter transference, right? We want to be kind, we want to be compassionate. Um, we want to set limits and whatnot, but we got to be aware of that transference, the feelings that the patients might have towards us, or that counter transference, right? The feelings and the attitudes and whatnot we might display towards the patients, right? So we got to kind of be careful of how those interactions and how, we got to check ourselves, right? And make sure that those, uh, those transference factors aren't happening. Okay. Because they can develop pretty strong in some of these personality disorders. Um, Again, we talk about therapeutic communication, right? Um, we use that as a role model, right? We can use that with our patients, but we can also use it to teach our patients, right? Like, hey, this is how this is why we don't use certain why questions, right? This is a way that we can word some of these things to kind of explore the situation, to get people to open up to talk to us, right? And there's some of the things that we could teach the patient too, to kind of advocate for them to kind of be more socially assertive, right? To start engaging a little bit more, to engage with people in a more healthy way, as opposed to using their emotions and manipulations. Um, Psychotherapy is the treatment of choice, right, for dependent personality disorder. Again, this is where CBT is coming up, DBT as well. And again, no specific medications for this, but as with all the other ones, if there are other things going on that are significant enough to address, like anxiety and depression and whatnot, we use medications for those types of things. So OCD, some of us have, a lot of us have an idea of what this looks like, and for the most part, um, it's pretty. I probably don't have a whole lot to add more than what you've already seen, but there are a couple things that I would like to add. Um, so this is pretty prevalent, on some level or another. I know some of us like to say, "Oh, well, I'm so OCD about this," and it's like, well, yeah, I mean, a lot of us have behaviors that are kind of OCD-like. Um, you guys probably think I'm weird, but when I have the volume on in my radio in my car, I don't like it on odd numbers, right? Go ahead and make fun of me. I know some of you are laughing, but I know there's some of you that know what I'm talking about. So, but this is like this is a disorder, right, in which things are kind of out of control, right? It's affecting people's relationships. It's affecting themselves personally. These people are usually aware of their behaviors, and it drives them crazy. It really bothers them. It's really characterized by this rigid, inflexible standard for other people and for themselves. Like, it's not just the behaviors, but they might have standards for other people, how they want them to look, how they want them to behave, right? Um, and usually people can't meet those standards, right? The behaviors can be very ritualistic, right? This is the part that most of us see. Most, I don't know, I'm sure, I know some of you have seen it. I've talked about that movie, As Good as It Gets, with Jack Nicholson and gosh, I always forget her name. She's blonde, but either way, that's a really good example, right? The very ritualistic behavior, very unrealistic expectations of the behaviors that Jack Nicholson wants to see out of Helen Hunt. That's her name. That he wants to see out of other people, right? Um, there's a very high preoccupation, right? So these people are very focused on the specifics of things, right? Like, and that can translate to specific things like how how their shoes are lined up before they leave the house, what colors clothes that they can wear that day, how many times they brush their teeth, how many times they wash their hands, whether so many times a day or how many times a week they clean their house, right? And so they are so focused on these things that it bothers them, and it really actually bothers them, and they recognize that, look, I'm really upsetting the people that I live with. I'm driving my wife crazy. My husband, he can't take it anymore. My friends, they don't want to go out with me anymore because I have these responses. I can't help myself, right? And so it's not like it's this. A lot of times, it's not like this issue where they don't recognize their behavior. It bothers them. So again, this is one of those areas where we want to guard against power struggles, right? And it's one of those areas where we got to be like, look, man, that's kind of ridiculous. I mean, just lock your door, right? Like, just lock your door and leave. I don't see why you have to lock your door 8 times, because that's one of the things you'll see too. Window closing, people open and close their windows and then open and lock their windows, so many times. One person that I saw in the clinic as well. He liked to count things in his pockets. So he would take everything out of his pockets and count it and put it back in and then take it back out and count it again just to make sure that he was leaving his house with everything that he wanted to. And it would drive his wife crazy and his kids crazy because when they would want to go somewhere, every time he has to take things out of his pockets and put them back in and take them back out and put them back in. And so some of us think like, well, dude, I don't understand what the problem is here. Just give your stuff to your wife or just count it once and be done with it, right? And so one, you want to check ourselves, right? Because this is a real issue. And then two, it's not going to do any good to argue against people, okay? Because again, this kind of goes into that second part, right? The patient is having difficulty with this as well, right? Like, the patient is already having a hard enough time with this on their own. They're already getting enough criticism from the people around them and on their own, right? So avoid those criticisms, avoid those power struggles, and always use that therapeutic relationship, right? Always remain professional. Um, so again, and this is one of those areas too where it's like you can kind of help people identify, help them work through what they can do to identify coping mechanisms, right? And it might even involve something really specific and small, right? Like for this person, he had to count his things 5 times, right? He had to count it 5 times before he left. So it's like, well, hey, like, what are you doing to like, so one of the things I talked about with him was like, well, what are you doing to like help with this? You're not really in therapy anymore. So what are you doing to what works for you, And oh, well, nothing, it's like, well, let's try this, right? Instead of 5 times, right? Try 4 times, right? Maybe get ready to leave your house 5 minutes earlier, only do it 4 times, and then see how that works, right? You know? And I'll be honest with you, I don't know whether that got far with him or not, but at least it gets people in that mind to think like, maybe there's other ways that I can address this, right? For this, patients do tend to seek help, as opposed to your narcissistic personality disorder, as opposed to your antisocial personality disorders. These folks recognize their behaviors. Again, they recognize how their actions are kind of affecting other people. They recognize how their selves are being affected, and they usually tend to seek help on their own. Um, some of the strong comorbidities with this are anxiety and depression. I would probably say anxiety is the biggest one. Um, this is usually comes out of, we talk about personality disorders and how they're in deep rooted learned behavior. And this is definitely one of them. This is one of those coping mechanisms that kind of comes out of trying to deal with your anxiety. And again, we're starting to see group therapy and behavioral therapy again, right? So probably not shocking for you guys to see at this point. Two of the medications for this are clomipramine. The other name for that is anafranil, and Prozac. So you'll see those used quite a bit in combination for OCD. The problem is that although those medications can help out, and clomipramine can actually help out quite a bit, the problem is that OCD is still very difficult to treat. The medications can help, the therapies can help, but very, very hard to treat. It can be pretty persistent. So I'll let you guys think about this, okay? A patient is admitted to your unit with has a personality disorder. So just try to think of some of the more difficult ones. So borderline personality disorder, narcissistic personality disorder. Think of the more difficult ones, right? Like antisocial personality disorder. I want you to think about what are some of the important areas to assess. I want you to think about 3 things, okay? Th things to assess when you're assessing your patient. Things to assess when you're assessing things as a team, right? When you're thinking about assessing your facility and your teamwork. And then 3, things to assess for yourself, okay? It doesn't have to be a long essay or anything. Just jot down a couple ideas, okay? For each of those, right? So yourself, the patient, and the team, okay? Um, I don't have any input on this. I'll be honest with you. I don't like this question. I love how I already put a little hash mark there that shows you where I was kind of playing with the mouse. So borderline, right? Splitting is definitely most associated with borderline personality disorder, right? Splitting is not just manipulation to get what you want. Splitting is putting people into those categories of you're either with me or you're not. You're either good or you're either bad, right? Antisocial, obsessive compulsive, and schizotypal personality disorders occur most frequently in men. Um, definitely in men. So I'd have to say that that's pretty in line with what we see in practice as well. Um, anyways, that brings our lecture to about 1 hour and 45 minutes. So if I'm honest, it's a little bit longer than I thought it would be, considering we're only covering personality disorders, but it's a little bit shorter than the last few weeks. A lot of applicability here, you guys. You're going to see a lot of these personality disorders quite a bit. If you haven't, I don't know if I would believe anybody that says they haven't seen some of this in one form or another. Okay. Again, when it comes to the personality disorders, all right, there is a spectrum that we normally see in people, right? There's like this spectrum of behaviors that we normally see. Um, all of us have had one point in our lives where we're acting a little borderline, right? All of us have had those moments in life where we're kind of acting a little bit OCD, right? So even then, like there's some kind of behaviors within a norm, right? These folks far exceed all of that, just like most other things we've talked about. Okay, so definitely think about those three factors. When it comes to going through these PowerPoints and whatnot in this lecture, definitely think about those three main factors. One, when we're assessing our patient and we're addressing our patient. Two, how we fulfill our self-assessments, the things we need to consider with how we address things professionally and how we're engaging with our patients from our end of the conversation. And three, our teamwork considerations. Okay, that teamwork consideration as far as dealing with these folks and helping treat these folks is pretty important, and that translates to no matter what setting you're in. It doesn't matter whether you're inpatient at NAMS or you're at outpatient mental health, or whether you're in cardiology, or whether you're in on call. It doesn't matter whether you're on the med surg floors. I don't care. You know, when it comes to dealing with these types of things and these types of behaviors, and you're going to see them everywhere, those are kind of the three factors that you really need to consider the most. Okay. So, anyways, thanks for listening. I hope this works out okay for you guys. Again, I miss seeing everybody in class, and I will be online Tuesday. What I say? I think I said that was the 30th, right? So Tuesday, March 30th, I'll be online from 9 to about noon to answer any questions, and not just to answer questions, but I'll be posting things as well to kind of have you guys answer back and kind of engage you guys a little bit. And then I'll also be online again later on that same day at 8 o'clock. Okay. But in the meantime, if you have any problems, if you have any questions or anything that comes up, let me know. Okay. Take care. Take care of yourselves and your families, and stay healthy.